Hi everybody, and welcome to our module on spirochetes. Spirochetes are bacteria with a long corkscrew shape. This is a drawing of what one might look like over here in the bottom of the page. In general, they're all difficult to grow and culture, and usually we use antibody tests, which is serology, to make a diagnosis of one of these infections. The three spirochetes you need to know are Leptospira, which causes leptospirosis, Borrelia, which causes Lyme disease, and finally Treponema, which is the cause of syphilis. So when I hear the word Leptospira, I have always thought of a mouse urinating in a lake where people swim. I know that sounds gross, but that's how I've always kept the characteristics of this bacteria straight. So Leptospira lives in rodents like mice, and they shed the bacteria in their urine, and it often gets into the water, and people get sick from swimming in contaminated waters like lakes. The disease can range from being asymptomatic to severe, which is true of many diseases. If people do get sick, they usually get a flu-like illness, which is pretty non-specific, fevers and rigors, myalgias and headaches. One thing that should always tip you off that this may be a Leptospira case in a board question is the presence of conjunctival suffusion. So these are red eyes, very similar to conjunctivitis, but they'll occur in combination with a flu-like illness in somebody who's recently been swimming. Leptospira can also cause aseptic meningitis, so this is meningitis where you don't grow bacteria, and that's because the bacteria is hard to grow on culture. And then a rare complication is something called Wales disease, where patients get liver damage and they become jaundiced. They can also get renal failure and have bleeding. The diagnosis is usually from a classic history or exam in a place like the tropics where this happens a lot, or there are antibody tests available. You treat this with the two antibiotics that are often used to treat unusual diseases, and those are doxycycline and azithromycin. And the classic case will be a surfer or a swimmer from the tropics who gets a flu-like illness and has very red eyes and also gets jaundice. This is a case of leptospirosis. Borrelia burgdorferi causes Lyme disease, and Lyme disease is named after Lyme, Connecticut. And if you know that, it can help you remember that this disease is common in the Northeast United States, places like Connecticut and Massachusetts. Is caused by a tick bite from the tick Ixodes scapularis. Larvae of this tick feed on mice, and mice are the reservoir for Borrelia, and then the infected adult ticks feed on deer. So it's often described as a deer tick, but don't let that fool you and think that deer are the reservoir for this bug. The reservoir is mice. The ticks can then bite humans, especially when they've been out in the woods where the ticks are found, and this causes infection with Borrelia. Now the ticks have to be attached for about 48 hours to transmit the bacteria, so a common scenario is someone who presents to a doctor who was just bitten by a tick that morning. They are not going to get Lyme disease. And as I said before, it's common in the Northeast US and it's named after Lyme, Connecticut. So Lyme disease has 3 stages, just like syphilis has 3 stages, and that's one way I remember that they're both spirochetes, because spirochetes tend to have these multi-stage illnesses. So the first stage of Lyme disease is called erythema chronica migrans. Most people just call it erythema migrans. And the classic finding is an expanding bullseye rash. This is a picture of one over here. Patients with stage 1 will also have flu-like symptoms. The rash will eventually go away, as will the flu symptoms, and then later patients will get stage 2. In stage 2, patients have neurologic and cardiac findings. The classic neurologic finding is a facial nerve palsy, so they will have droop on one half of their face. The other classic finding in stage 2 is a cardiac finding of AV block. So this is an EKG down here, and you can see that there's a P wave here, and there's another P wave here, and these aren't being conducted. So this patient has a bradycardic rhythm, and many of the P waves are not conducting to cause QRSs. So always remember the classic findings of stage 2 Lyme disease are facial nerve palsy and AV block. Stage 3 is the most confusing stage of Lyme because it has a lot of different symptoms. Patients can have arthritis, often of the knees. They can get neuropathy, so they'll have pain and paresthesias in various joints. They can get a mild encephalopathy with cognitive disturbance. There is a European version of Lyme disease, and patients with this variant of the infection sometimes get a rash in stage 3 called acrodermatitis chronica atropicans. It's a blue-red discoloration of the skin, very uncommon in the United States. And the treatment for Lyme disease is to use either doxycycline or ceftriaxone. There is a rare condition called relapsing fever that is caused by Borrelia other than the Borrelia burgdorferi that causes Lyme disease. In the United States, this condition can be caused by Borrelia hermsii or Borrelia turricaudae. It's transmitted by tick bites. In the developing world, there's a bacteria called Borrelia recurrentis that causes this illness. It's transmitted by the bite of a louse, which is an insect, and it's spread from person to person by the louse and can cause epidemics. The symptoms of infection with any of these bacteria are relapsing fever, obviously. But the reason you get relapsing fever is what's high yield to know for the board. So there's antigenic variation of the bacteria that causes the recurrent fevers. So as subsequent generations of the bacteria grow inside the body, they change antigens on their surface. This allows them to evade the immune response and begin growing again, and then the body mounts an immune response and the fever returns. And this cycle repeats itself, and that's why the fever relapses. So the most important thing to know about these non-Burgdorferi Borrelia is that they cause relapsing fever through antigenic variation. Now let's talk about Treponema pallidum, which causes syphilis, and this is a very high-yield bacteria for you to know for step 1. Syphilis is a sexually transmitted disease, and you should know that you can see the spirochete under the microscope using a technique called dark field microscopy. This is a picture of some syphilis bacteria using dark field microscopy. This technique filters out the white light that doesn't pass through an organism, and it makes the organisms bright white against a dark background. And you can see that these are long twisting bacteria just like you'd expect for a spirochete. And as I said before when I was talking about Lyme disease, syphilis has primary, secondary, and tertiary stages just like Lyme disease. Primary syphilis occurs 2 to 3 weeks after someone's been exposed to the bacteria by sexual activity. Primary syphilis causes a painless chancre, which is an ulcer classically on the penis. This is a picture of one right here. It's usually a centimeter or 2 in size. It's often a little bit raised. And it's often unnoticed because it's painless, so sometimes people won't notice the ulcer and then it will resolve and they will progress to stage 2 without having any knowledge that they ever went through stage 1. The classic finding of secondary syphilis is a rash. It is a maculopapular rash that covers the extremities and involves the palms and soles. So only 3 rashes classically involve the palms and soles, and syphilis is the most important one. The other 2 are Rocky Mountain spotted fever and Coxsackie virus. In stage 2 of syphilis, people often have flu-like symptoms like fever and headache, malaise, sore throat, myalgias. None of these are very specific for syphilis. And then another characteristic finding of secondary syphilis is called condyloma lata. These are large, raised gray to white lesions. They often look like cauliflower. They're found in moist areas, sometimes inside the mouth, often in the perineum on women. You can Google this online and find lots of examples. They're often close to where the chancre was, so this may reflect direct spread. And one very high-yield thing to know is that the condyloma lata and the chancre are loaded with treponema. So one easy way to make a diagnosis of syphilis is to take a swab of the chancre or the condyloma and put it under the microscope and use dark field microscopy to visualize the spirochetes. So here's a summary slide just to help to remind you of what I said before. Most maculopapular rashes spare the palms and soles. The 3 that don't that you need to know are syphilis, Rocky Mountain spotted fever, and Coxsackie, which causes hand, foot, and mouth disease. After stage 2 resolves, patients can progress to stage 3 or tertiary syphilis, and this sometimes doesn't happen for many years after the rash. Some of the findings of tertiary syphilis include gummas. Gummas are a form of granuloma. They're a mass lesion that can appear anywhere. They can be seen on the skin. You can find them in the liver at autopsy. They're often mistaken for tumors. Another tertiary syphilis finding is aortitis. Recall that the vasa vasorum are the blood vessels that supply blood to the aorta, and they can become inflamed in tertiary syphilis. This puts patients at risk for aortic dissection. And then finally, neurosyphilis is a component of tertiary syphilis. There are many, many symptoms of neurosyphilis, but they include things like meningitis symptoms, dementia, nerve palsies. In the 1800s, many people in insane asylums were there because they had developed dementia related to neurosyphilis. 2 special manifestations of tertiary syphilis that you should know about are the Argyll-Robertson pupil and tabes dorsalis. Argyll-Robertson pupils are a manifestation of neurosyphilis. They occur when syphilis involves the brain. And patients who have neurosyphilis and Argyll-Robertson pupils will have very small pupils on examination, and their pupils will constrict to accommodation, but they won't constrict when you shine light in them. And I talk about this in more detail in videos on the eye in the neurology section. Tabes dorsalis occurs when syphilis involves the spinal cord as part of tertiary syphilis. This refers to demyelination of the posterior columns, which are this part of the spinal cord here. The posterior columns carry sensory information about proprioception, so when this is lost in patients with tabes dorsalis, they develop a wide-base gait as they try to maintain their balance, and they can develop ataxia with things like falls and loss of balance. And I talk about tabes dorsalis in more detail in videos on the spinal cord in the neurology section. Let's talk about how you diagnose syphilis. So remember what I said before, if a chancre is present or condyloma lata is present, those things are loaded with spirochetes, and you can sometimes make the diagnosis using dark field microscopy. But if you don't have those options, you have to use a series of blood tests, and it's high yield to know how these work for your boards. So the first two blood tests are called VDRL and RPR. VDRL stands for Venereal Disease Research Laboratory Test, and RPR stands for Rapid Plasma Reagent Test. Both of these are called non-treponemal tests, and they're called that because they are non-specific tests. They're used as screening tests, and if they're abnormal, you have to follow them up with a more specific test. In both cases, you take the patient's serum and see if it reacts with specific antigens. In the case of VDRL, it's a cardiolipin antigen. Reaction with any of these antigens, either the one in VDRL or the one in RPR, is non-specific, but syphilis patient's serum will react, and this will be reported as a positive VDRL or RPR. Just because it's positive doesn't mean they have syphilis. It's a screening test, and you have to follow it up with a more specific test, which we'll talk about in a minute. And one thing to know is that for neurosyphilis, you need to test the CSF. A positive serum test means that the patient has had syphilis before, but it doesn't necessarily mean that the spirochete has gotten into the central nervous system. It's very difficult to diagnose neurosyphilis. There are many false negatives, but the key point to remember is that you've got to test the CSF directly. So as I said before, the VDRL and RPR tests are screening tests for syphilis. They are sensitive but not specific. And one of the reasons they are not specific is because many other conditions can give you a false positive result. In other words, you can get a positive result on one of these tests but not due to syphilis. You have to remember that both the VDRL and RPR tests are simply antigen tests. They have a commercial antigen, for example, the RPR antigen. And the reason this test works for syphilis is because syphilis antibodies will react with this antigen. However, many other conditions cause antibodies that will also react with this antigen. For example, mononucleosis can cause antibodies that react with the RPR antigen, so can rheumatic fever, lupus, and leprosy. And even some women who are pregnant for reasons that are poorly understood can develop antibodies that react with the RPR test. So a positive test result does not necessarily indicate syphilis, and you have to follow it up with a more specific test. The more specific test for syphilis is called the FTA-ABS. This stands for fluorescent treponemal antibody absorption. And this is called a treponemal test because it detects antibodies against specific treponemal antigens. And this is very specific, and the results are reported as reactive or non-reactive. Now you may be wondering, why not just order this test on everybody and skip the others? Well, the reason is because historically this test has been more complicated and expensive to perform. So the VDRL or RPR were used as a screening test, and then this was only done if patients had an abnormal non-treponemal screening test. Syphilis is one of the torches infections. It's very dangerous during pregnancy, so let's talk about that now. Congenital syphilis occurs when the spirochete is transferred from the mother to the fetus, and this can occur as early as the first trimester, so mothers need to be screened early in pregnancy. And babies who get congenital syphilis are often born to mothers who had no prenatal care, so they were never screened. And the findings in the baby can occur early or late. So we call findings that occur in the first 2 years early, and then other findings late findings. So early findings of congenital syphilis include things like a big liver in the baby or the young child. These children often have runny noses. They can get a maculopapular rash, just like patients in the second stage of syphilis. These are small red or pink spots. They can be on the back or the buttocks, the thighs, or the soles. And then one characteristic feature that you need to remember about congenital syphilis is that it can affect the bones. So babies with congenital syphilis often have long bone x-rays that are abnormal. There are lots and lots of abnormalities reported. I don't recommend you try to understand them all, but just know that the bones may have abnormal shapes or may have abnormal features when x-rays are taken. And then the really horrible thing about congenital syphilis is that these children will be disfigured for life. So they will have findings of their ears and nose called a saddle nose, where they don't have a nasal bridge. They can have hearing loss or deafness. Their teeth are abnormal. There's a finding called Hutchison's teeth, where the teeth are notched and peg-shaped. Another finding is called mulberry molars, where they have maldevelopment of their molars. And then they get bowed legs called saber shins. So because the mother passed syphilis to the baby, means that the child is going to be deformed and disfigured for the rest of his or her life. Syphilis is one of the few infections that can still be treated with penicillin. Many bacteria are resistant to penicillin, but treponema is not, and you can still use plain old penicillin G. And there's a classic reaction that occurs when you start treating syphilis called the Jarisch-Herxheimer reaction. This is a flu-like syndrome after starting antibiotics where the killed bacteria generate an immune response, and it is self-limited. And a classic board question is to show you a patient with syphilis who gets penicillin and then gets sick. And some of the answer choices will say that you chose the wrong antibiotic or that it's resistant, but you need to know that this is just a normal reaction to the administration of penicillin G, and the treponema are starting to die. And that concludes our module on spirochetes.